Assalamu alaikum. Today's topic is benign enlargement of the prostate gland. So, before starting about the benign enlargement of the prostate gland, we would discuss something about the prostate. Prostate gland, the anatomy of the prostate gland, it is present in the pelvis and it is consisting of a central zone and a peripheral zone and the transitional zone. The central zone is in the center, peripheral zone is outside it, and the transitional zone is in the below it. It consists of smooth muscles and it has glands. The physiology, it secretes, these glands secretes hormones. The hormones contains the androgens. Dihydroxytestosterone is developed from the testosterone, and from the dihydrotestosterone is 5 times more potent than the testosterone. So this is actually the function of the prostate gland, that it secretes androgen, which are the male sexual hormone. Today's topic, the benign prostatic hyperplasia, etiology. There are certain theories. Number one is the hormonal theory. According to the hormonal theory, in the advancing age, the male hormones decrease, whereas the female hormones, as both the male and female hormones are present in both males and the females. So in case of males, the male hormones decreases, so the ratio of female hormones increases. This disturbing ratio of male to female hormones, that is the testosterone and the estrogen, makes the prostatic gland hypertrophy, and hyperplasia occurs in the cells. This usually occurs in the age group of 50 years or above, as with it the bladder outflow obstruction occurs as the gland increases in size, the cells increases in size, they obstructs the bladder outflow and develops the urinary retention. Pathology, submucous glands in transitional zone forming nodular enlargement. There is a nodule formed in the prostate gland, which we can see on per rectal examination. When a patient comes to us with retention of urine or decreased urine or such symptoms, then we do the PR examination. We find that the submucous gland in the transitional zone forming nodular enlargement. There is an enlarged nodule. They affects the prostate glands, and symptoms, lower urinary tract symptoms and the bladder outflow obstruction symptoms occurs. Prostatic urethra enlarges twice the length, and the bladder musculature hypertrophies and increases blood flow to bladder. Hematuria occurs. As the hematuria, because the bladder becomes hyperemic, and on inflammation, that hyperemia results in exclusion or oxidation of blood in the urine. Signs, symptoms: lower urinary tract symptoms. Lower urinary tract symptoms include frequency, urgency of the urine, hesitancy. Patient cannot avoid urine everywhere, but he has to because there is urgency. Patient cannot retain the urine. There is urgency of urination. Then straining. Patient, as the prostate gland enlarges, patient has to strain, and when the patient strains, the further retention occurs. He has to relax, and then the patient can pass the urine. If he does not relax, the urine further accumulates within the bladder. Weak stream. When the patient passes the urine, the parabola that is formed by the urine, that is not formed, and the urine falls immediately in front of the urethra. Dribbling of urine. As the bladder becomes full, the drop by drop urine comes out of the urethra. That is called the dribbling of urine. Retention. As the prostatic gland obstruct the bladder outflow, so there is retention of urine, and the bladder becomes distended with the urine, and we can feel it on palpation of the lower abdomen. Frequency and urgency. These are the signs of the lower urinary tract infection. Incontinence. Again, as the bladder becomes full of urine, incontinence starts. Nocturia. As the patient lies down on the bed and relaxes, the patient passes urine immediately. That is the nocturia. Secondly, he has to wake up 2 to 3 times in the night to pass the urine. Otherwise, his sleep is disturbed. Aneurasis. Aneurasis is again when the patient relaxes, he passes the urine on lying down. Bladder outflow obstruction. This is because of the hypertrophy of the musculatures. Bladder neck stenosis. Stricture hypertrophy. Neuropathic condition. The nerves becomes damaged, and they are not properly, the sphincter is not properly constricting and relaxing. There is nerve damage. Acute and chronic retention of the urine. When the case is of shorter duration, it is acute retention, and when the case is of longer duration, more than 3 months or 6 months, then it is of chronic retention of urine. Hematuria. As we discussed, there is the blood passes in the urine as there is congestion of the bladder and the urethra. Investigations. Urine DR and CS. Urine DR shows that there is pus in the urine, red cells in the urine, cast, and culture sensitive because the urine stays within the bladder and does not pass easily and stays more in the bladder, so there is infection, and that infection can be represented or seen in the blood urine CS with the bacteria present in it. Mostly it is the E. coli. As the urine stays within the bladder, it causes ascending UTI, and because of that ascending UTI, there is high blood urea and blood creatinine, serum creatinine. The normal ratio of urea creatinine is 40:1, and this normal ratio is disturbed. 40:1 is disturbed, and we can see that there is urea is more than 60 and creatinine is more than 1. IVU, intravenous urogram. Normally there is no residual volume in a normal person, but in case of prostatic enlargement, we find that the residual urine is more than 200 ml. Ultrasound KUB is the first investigation that is done and to check the enlargement of the prostate gland, the retention of urine, and the transrectal prostatic scanning. Again, the transrectal probe is used further to check the prostate gland enlargement. Cystourethropy, a fiber optic instrument. Cystoscope is passed through the urethra, and when passing through the urethra, we can see the urethra and then the bladder, and we can see the interior of the urethra and the bladder, and what is its condition, what is the on the way we can see the prostate, whether it is enlarged or not. PSA, prostatic surface antigen, is the investigation that is done in benign prostatic enlargement. It is less than 10. 2.5 to 4 is the normal millimoles per liter, and it is less than 10, and if it is found to be more than 10, then it shows that there is malignancy of the prostate gland. Treatment may be conservative. Conservative means we are not operating immediately on the prostate gland, the enlarged lobe, the enlarged gland. We are just looking, and we can try to solve it with the conservative by drugs. Drug therapy, alpha blocker and 5-alpha reductase inhibitors. Unani drug, Gulmandin. Surgery, transurethral resection of the prostate gland or the open prostatectomy. The old method was the open prostatectomy through the two different routes, that was retropubic or transvesical or transperineal, that is through the pubic region or through the vesical region or through the perineal region. Now transurethral TURP is the talk of the day, and TURP is transurethral resection of the prostate gland, and the fiber optic instrument is passed, and the obstructive element, the gland part that is obstructing the passage of urine from the bladder to the urethra, that is cut and cleared, and the way is cleared. Complication of the surgery, local complications, sepsis, bleeding, hematoma formation, incontinence of urine. If the stricture is damaged, stricture urethra may occur if fibrosis occurs, and then bladder neck obstruction. Again, if there is fibrosis, then bladder neck obstruction may occur. Reoperation may have to be done if there is retention of hematoma, and we have to clear it. Water intoxication, when clearing the bladder, the normal saline is given, and if too much of it is given, then it may result in water intoxication. Sodium retention, etc. Pulmonary and CVS, cardiovascular system complications, that is anesthetic complications. Osteitis pubis. Osteitis pubis is the needle of the anesthesia when giving the lumbar anesthesia. If it touches the pubic bone, then it may cause osteitis pubis, that is inflammation of the pubic bone. That corrects itself, self-limiting disease, but it takes a longer time. Reference is Short Textbook of Surgery by Bailey Love, 26th edition. Thank you. I hope you would understand. We are clear.